Hello, my name is Cory Rohlfsen. I'm assistant professor of internal medicine at UNMC. I am super excited to give you a talk on aspirin on trial, weighing the risks and benefits for primary prevention. I've never given a talk at ACCP before, and certainly have never recorded one for Zoom. So this is new for me, but I really appreciate your attention and look forward to answering any questions that you have at the end. So I've worked a little over 2 years as a primary care physician in an academic setting, and one of those years was my chief year at UNMC. And during that time, 3 randomized controlled trials had just come out, and no one knew what to do with aspirin because we had been giving it for years as primary prevention, and now there was growing evidence that perhaps this was the wrong approach. And here is the ACC/AHA updated guidelines from March of 2019. And as you can see, there's not much additional clarity there. So admittedly frustrated, I have absolutely immersed myself in the literature and have developed a little bit more nuanced approach, which I hope that you find helpful in your daily practice. Why does it matter to have a more nuanced approach? Well, in a 2017 survey, there's about 30 million people estimated to be taking an aspirin, 7 million of whom are doing that without notifying their doctor. And like most over-the-counter meds, patients aren't going to report this when asked for their med list. In fact, a lot of people don't think over-the-counter meds or medications at all. And as I'll allude to, this indiscriminate use of aspirin is probably not a good idea. I have no financial disclosures or conflicts of interest, and here are my objectives. So after defining the scope of cardiovascular disease in the United States, we'll review the mechanism of aspirin and outline how guidelines have evolved over the years by reviewing the available evidence. And then we'll end briefly by discussing the 2019 ACC/AHA Executive Summary for the primary prevention of cardiovascular disease, followed by practical tips on how to approach aspirin when patients ask about it for primary prevention. So before we start, I thought I might frame this in the context of a patient to keep this as clinical as possible. So let me introduce you to Mr. Evans. He's a 68-year-old white male and presents for his annual physical. I've listed his past medical history. He does have occasional minor bleeding from hemorrhoids. He's on thiazide for hypertension. He's on simvastatin for hyperlipidemia. And he's also on an aspirin, which he takes for primary prevention, mostly because his father had died of a devastating stroke, and so he obviously wants to avoid that. He's never smoked. He's very active. I've listed his vitals. His exam's unremarkable. LDL was 111. Some recent labs shown there. And then I've also calculated his 10-year ASCVD risk, which lands him in the intermediate risk category. So the task of this talk today is to hopefully allow you to be more comfortable in addressing the question, should he continue the aspirin? So I promise we'll come back to this. So it's not a surprise that cardiovascular disease is common. It's still the leading cause of death in the United States. There's 1.5 million heart attacks and strokes each year, and the economic burden is not insignificant. So some estimates nowadays show that we're losing about $1 billion a day due to preventable cardiovascular events, which represents about 1 to 2% of the national GDP. And there was a study in 2016 that showed this could actually double by 2035, which is absolutely terrifying. And keep in mind that this includes just heart disease. It does not include stroke, which is the 4th leading cause of death. And again, the majority of strokes are thrombotic in origin, so you might as well lump them to one and the same. So this is a graph that shows the cardiovascular disease mortality, deaths in thousands on the y-axis, over the course of the last century, from 1910 to 2000. And you'll notice that cardiovascular disease significantly increased. And the main reason for this is because of improved sanitation, access to hospitals, antibiotics like penicillin. Basically, just to put it simply, if you didn't die from a pneumonia or an infected wound, then you could live long enough to die of something like a heart attack or stroke. And keep in mind the number one risk factor for atherosclerotic disease in general is age. And I also thought that this graph was a little bit uncanny. This shows the prevalence of smoking across the 20th century, which peaked in 1967. interestingly, at the same time as cardiovascular disease burden peaked. And as tobacco cessation has decreased over the past few decades, so has the cardiovascular disease death. And so this is a more promising curve. This shows the decreasing death per 100,000 of heart disease up until 2014. So the latter half of the 20th century is a different story, and there's a lot of different reasons for this. It's kind of fun to think about, so I'm going to go through them quickly. So advent of cabbage, angiography, insurance, the first cardioselective beta blocker in 1976. The first statin was approved in 1987. And then interventional cardiology with first, second generation stents, ICD, and then also nutrition. I think that that's an important consideration. It is kind of funny that you can tell which decade a millennial was born based on the food pyramid that they were taught. And then finally, I don't think we've even seen we have not seen the beginning of the effect that PCSK9 inhibitors will have. I'm sure you're asking at what point, what role does aspirin have to play? And this is what the talk is all about. Aspirin has an interesting story. It's one of the oldest drugs. It's been around since 1899. And so it actually celebrated its 120th birthday last year. What's interesting is for the first half of the 20th century, aspirin was only approved for its antipyretic and its analgesic properties, so reducing fever, reducing pain. It wasn't until 1985 that the FDA approved aspirin after a heart attack. Just some fun context. And I wanted to have one slide on secondary prevention just to show you what this talk is not about. So we all know that aspirin has a role to play in prevention of heart attack after someone's already had a heart attack, or after someone's already had a stroke or a mini stroke, or if they have known coronary artery disease with history of intervention. And so the number needed to treat for secondary prevention is typically under 30. I think that's really good context when I start to cite number needed to treat throughout the rest of the talk when talking about primary prevention. So this is what the talk is about today. So people who have never had a heart attack, never had a stroke, never had a stent placed, is aspirin beneficial in these groups? And just to flesh out the public health conundrum a little bit better, I want to do a fun thought experiment. So there's about 800,000 MIs annually, and I've rounded 2019 data just to make the math a little bit easier. But if I was to give you two pools of people, those with high risk, known atherosclerotic vascular disease, and then the primary prevention group, which group in the next year do you think is going to have more heart attacks? If you said the lower risk group, you would actually be correct. And the reason for this is because there's 15 times as many people in the low risk group than there are in the high risk group. Very interesting. So even though the high risk group has a much higher risk individually of having a heart attack in the next year, most heart attacks in the next calendar year are going to come from the quote-unquote low-risk group. And I say quote-unquote because nothing about that group makes them low risk, because as you're probably thinking about the patients on your panel right now, you can immediately bring someone to mind who is a ticking time bomb in that group. And we're just not good enough at predicting who needs to be on an aspirin, who shouldn't be. And recommending indiscriminate use to everyone in that cohort is not a good idea, as I'll allude to in a few slides. So people have thought extensively how to risk stratify. And so is patients with hypertension, hyperlipidemia, would that cross the threshold of aspirin therapy? What about CAD equivalents like peripheral vascular disease or diabetes? Is that sufficient enough? What about pro-atherogenic states like rheumatoid arthritis or lupus? Or you could have even more precise risk estimates through risk calculators like Framingham, Innerheart, or the most recently developed, the ACCP pooled cohort equation, which is super nice. Epic or whatever EMR you use, I'm sure calculates it for you, that 10-year risk of having a heart attack or stroke. Unfortunately, most of these risk calculators have been shown time and time again to overestimate risk. And so here's a nice study from 2016 that took primarily low-risk patients, and it showed, so the y-axis shows the 5-year event risk, and so they follow these patients for at least 5 years, and it showed that in the blue, the observed rates were on average 4 times lower than what the calculator would predict for the expected rate across all risk groups. I guess I'd be remiss without mentioning the possible role for ABIs, high sensitivity CRP, and coronary artery calcification scores. For statin therapy, I think that it's a reasonable thing to consider, but nowhere in the guidelines are these tools recommended to risk stratify for aspirin therapy, and the main reason for this is it would be cost prohibitive to do that, and I just don't. Even though there's growing data, and if you know what you're doing, it could work, especially with some newer data with high sensitivity troponins, I just would not recommend that at all for aspirin use. And then just to contextualize further, that even in higher risk groups, the PC is still going to overestimate your risk, and that's shown in red for primary prevention. Obviously, there's going to be higher observed rates for the secondary prevention cohort, which is shown in blue. All right, let's review the mechanism of aspirin. So aspirin has 2 main downstream effects. First is platelet inhibition through acetylation of COX-1, which blocks production of thromboxane, thereby not allowing platelets to aggregate. Its second effect, though, which primarily occurs at higher doses, is inhibition of prostaglandin, or prostacyclin synthesis, through inhibition of COX-2. So because prostaglandin is needed to maintain perfusion to the bowels and kidney, aspirin in higher doses increases the risk of upper GI bleeds and renal failure, and this effect is obviously much more pronounced and clinically apparent with a 325 milligram dose than an 81 milligram dose. So if you're using aspirin to reduce fever, pain, or inflammation, this is also the dose that's more likely to cause upper GI bleeds and renal failure. And just to review how aspirin helps in the setting of an MI. So please remember what's actually happening when ACS occurs. The plaque that's full of those foam cells and nasty inflammatory cytokine milieu ruptures, which rapidly leads to a clotting cascade of platelet aggregation, followed by thrombus formation. And if you block that platelet plug, it's much less likely that thrombus will form, hence avoiding major blockages of coronary arteries at the site of plaque rupture on the day that, God forbid, you have a heart attack. Please keep in mind that statins have anti-inflammatory properties. They stabilize plaques, and they reduce the formation of lipid-laden plaques by reducing the amount of LDL in the first place. So whether or not aspirin has these pleiotropic effects is unclear. I personally have doubts about the data, and I believe the biggest benefit to having aspirin on board is the day that you have a heart attack, not the days preceding it. What's interesting about patient risk factors for GI bleeding is that they're almost identical to the risk factors for MI. This means that the same target population who's likely to benefit most from aspirin therapy is also the population who's at highest risk of bleeding. And so a concrete example of this can actually be borrowed from the nephrology literature. In CKD patients, a Cochrane meta-analysis from 2013 showed that aspirin can prevent cardiovascular events without any effect on mortality, but as GFR decreases and patients start to require dialysis, there's been good observational data suggesting that prophylactic use of aspirin actually increases mortality. So at a GFR of 45, you might prevent a few non-fatal MIs. But then as the GFR falls closer to 15, you're now increasing mortality. I only mention this because I don't want anyone being misled into thinking that the favorability of aspirin's risk to benefit profile just magically improves as patients accumulate cardiovascular risk factors in general. It does not. CKD is one example, but there are other examples as well. All right, so let's talk about the risks of bleeding with numbers. Here is the non-nuanced approach. So if you took all comers from every randomized control trial done on aspirin, The number needed to harm for all major bleeds would be about 250. The number needed to harm for specifically brain bleeds would be about 1,000. But just to keep it simple, you'd probably use relative risk if you wanted to scare someone away from aspirin, and you can tell them safely that aspirin doubles their risk of bleeding. But if you wanted to convince a patient to take aspirin, then you'd use absolute risk. And you could tell a patient that by taking aspirin daily, it increases their risk of bleeding by only 0.1% annually. In other words, it would take 10 years for their risk to be even 1% higher than their baseline risk. But we know that it's more complicated than that. And that's why I love this study from the European Heart Journal in 2013 that demonstrates the number needed to harm for aspirin can vary 100-fold depending on age and other risk factors. So clearly, we have to have a little bit more nuanced approach to this, and you'll notice that there's obviously a difference between age 50 and 70 or 80. The number needed to harm, if you took every randomized controlled trial patient between age 50 and 60, is closer to 200 to 300. So one meta-analysis mentioned 250, but it kind of depends on which RCT was included. The other important point is that aspirin in higher doses is about a 30% higher risk than the low doses of 81 or 100. And I think now we can transition into talking about how societal guidelines have evolved. So depending on how you include the trials, I'm going to include the 11 because if some meta-analysis included 13, but that included some peripheral vascular disease patients, which is arguably not primary prevention. So if you just look at the 11 trials that were pure primary prevention, I love this slide, this analysis, and it takes a little bit to orient to, so I'm going to do my best here. On the x-axis below, you see all of the randomized placebo-controlled trials that were done for primary prevention of aspirin, dating from 1988 on the right to 2018 on the left. The blue bars above show the percent of patients within each study that were on a statin, and the red bars below show the 3 trials that showed net benefit for aspirin in preventing a heart attack or stroke. And then even below the absolute risk reduction, below the red bars, is the number needed to treat. And you can see that it's decreasing from right to left. So there's 3 main take-home points that I want you to notice. First, statin prevalence has increased over the past several decades. And as it has increased, the absolute risk reduction for aspirin has decreased. That's shown pretty obviously on this slide, but if you're not convinced, we can go a little bit further. Next, I want you to see that the number needed to treat, so on the rare occasion that aspirin did show a net benefit, the number needed to treat has increased over the years. And only one trial in the past decade has shown benefit. That's the Japanese primary prevention trial in 2016, shown there on the left-hand side. And you might want to know, as part of that study, that over 70% of those patients had an indication to be on a statin, yet less than half of them were on a statin. And obviously, no patients from the United States were included in that study. The one that had the most benefit was the physician health study on the far right, where patients were enrolled before 1989. Obviously, nobody was on a statin back in 1989. So when interpreting this data and looking at meta-analyses, you really have to consider what has changed in this evolving landscape of risk factors. So I took the liberty to calculate the number needed to treat based on studies after 2000 or before 2000. And this is all included in the supplemental index of these studies, but it wasn't published. And I assume the reason for this is because the results are no longer significant, so do interpret this with some caution. But this signal is pretty compelling. The number needed to treat, if you only include the studies after 2000, when statin prevalence started to increase, jumps from 218 to 1,064. That is a significant increase. And what's interesting also is the MI event rate was different between these two populations. So clearly, these populations were different. So before 2000, the event rate in these studies with over 50,000 patients was 2.39%, but this decreased to 1.83% after 2000, involving over 100,000 patients. So let's dig a little bit deeper into that and find out what's happening. So before 2005, an MI was defined as CKMB elevation, which we all know is a less sensitive marker, meaning that if you had biomarker positivity, you were probably having the real deal. You were having a type 1 MI. Whereas now, since 2005, heart attacks are defined as troponin elevation, many of which are type 2 MIs. And so with increasing noise, you would have to recruit that many more patients to see a signal effect. Also, there's much less statin use, as I talked about, and significantly more smokers. So in 1990, there was 25% of the population who smoked. This decreased to 20% by 2005. And in 2017, when the 3 most recent randomized controlled trials were conducted, the prevalence of smoking in the United States had dropped to 14%. And you'll just have to take my word for it that hypertension, hyperlipidemia are better controlled nowadays. I've got some slides at the end if you'd like me to prove it, but this is mostly attributed to wider availability of generic drugs. So the take-home point in red below is that whatever effect that aspirin has in preventing heart attack or stroke in a primary prevention population is going to be blunted if that risk is already being driven down. Okay, so in a modern era where risk factors are better controlled, the additive effect of aspirin in preventing heart attack is blunted. So let's talk briefly about a meta-analysis from 2009, because I think it's important context for guideline changes. I promise I'm not trying to get into the weeds too much. Anything I bring up is something that informed a guideline change, so stick with me. So this looked at 5 to 6 the randomized controlled trials back in 2009, and the major finding was that there was a statistically significant reduction in MI for all patients, non-fatal MI. I will say it now and I'll say it again, not a single randomized controlled trial nor meta-analysis has ever shown mortality benefit, cardiovascular mortality benefit in any population for primary prevention with aspirin. But this did show prevention of MI, and a subgroup analysis did show prevention of ischemic stroke in females. And all this was largely driven by the Women's Health Study, which was published in 2005, which was the first major cohort involving women. Notice vascular death had a trend towards being less so, but was not statistically significant. All right, and then the other thing that this study did, which was nice, is it compared the secondary prevention trials and showed the order of magnitude difference in number needed to treat. Clearly, that was important. And then also, because it had enough data to include hemorrhagic strokes, it was showing for the first time that there was an actual number needed to harm for brain bleeds, which is extremely important if you're going to prescribe this across an entire population. But again, no significant reduction in cardiovascular mortality in primary prevention. So if you look at the scale weighing the risks and benefits, it's kind of a wash. It's pick your poison. Yes, you'll prevent a few heart attacks, but at the same time, you're going to have to accept the bleeding risk. And the context of this is it was 2009, and things have shifted since then. But I really like their conclusion, so I'm just going to say it. So drug safety, like vaccine safety, is of particular importance in public health recommendations for large, apparently disease-free populations. there should be good evidence that benefits exceed risks by an appropriate margin. Hence, although the current available trial results could well help inform personally appropriate decisions by individuals about their own personal use of aspirin, they do not seem to justify general guidelines advocating the routine use of aspirin. All right, so here is a brief summary of all the guideline changes. Very, very exciting. I think everyone can remember back to the USPSTF guidelines from 2009, where all men age 45 to 80 were recommended to have an aspirin to prevent a heart attack, and all women age 55 to 80 to reduce stroke. And again, this was informed by that ATT collaboration group, and there was another meta-analysis by Deboraitis et al. That confirmed this sex difference in men and women. And just please keep in mind that the inclusion criteria for all of these patients was that they were low bleeding risk. Next came the ACCP, which was the first group to acknowledge this growing body of evidence that aspirin could actually prevent cancers. And there were 3 cancers in particular: esophageal, colorectal, and lung, all adenocarcinomas. And the importance of this study was a retrospective study that looked post hoc at patients that were involved in cardiovascular reduction studies. So this was not intended to look at cancer. And so over the course of 5 to 10 years is when you start to see the signal. That's one important piece. But the other important piece of this is that critics, because it is retrospective, they don't know when patients had colonoscopies or bled. You could easily criticize this by suggesting that once patients were put on aspirin, they'd bleed and have earlier identification of cancer. That being said, the USPSTF did adopt the guidelines in 2016, and there's a wonderful document that talks about this growing body of evidence. It's not made up. Aspirin does reduce prostaglandins, which reduces angiogenesis and metastasis in several cancers, and that data is accumulating day by day. And is very exciting. The Lynch syndrome literature actually has aspirin prophylaxis as the standard of care, which is what started all of this. All right, and then I think most internists and primary care doctors learned the 2014 updates from the American Heart Association, ACC, and American Stroke Association, that anyone with a risk greater than 10% deserves to be on an aspirin who is otherwise low bleeding risk. This was wonderful because it just populated into your EMR, and if it was greater than 10%, it's a good idea. But as statin prevalence increased, I mean, there are some estimates that statin prevalence increased 64-fold from 2000 to 2014. You'll remember that only one randomized controlled trial showed a reduction in MI out of the 9 trials in the last 20 years. So this is fairly significant, and I think puts it into context what we're talking about. So as that data consideration was taken into account, the Canadians were first to say aspirin's not recommended, followed shortly after in 2016 by the European Society of Cardiology. Granted, the most recent USPSTF guidelines say take aspirin for 10 years, and I didn't understand the reason for this, but again, it's based on that cancer prevention data, so it's kind of this combined perspective. And it's respectable because a lot of the cardiology guidelines, they don't take into account the potential risk reduction of cancer. It's just the bleeding and cardiovascular risk. And then the yellow dot represents what I started the slide with, where low-dose aspirin might be considered for primary prevention of ASCVD among patients age 40 to 70, but again, that's now a grade 2B recommendation. And I skipped the ADA recommendation because diabetes is extremely heterogeneous, but I'm going to tackle it shortly here, just to be very brief. This is probably the most famous study from the New England Journal in 1998. It took patients with diabetes, and as you can see, the yellow line, diabetic subjects without a prior MI, had the same survivability as the green line, non-diabetic patients with a prior MI. So this was the evidence that supported treating diabetes as a CAD equivalent. Now, the average A1C for this cohort was 8.5, and patients had had diabetes for 8 years. What I love about this study is the red line showing survivability approaching 50% at 8 years if you're a patient with diabetes and a prior heart attack. So this is just contextualizing the risk for diabetes from a cardiovascular standpoint. And I think that red line is the reason that most primary care doctors show up to work every day. You can make a major difference in their lives. Okay, it's not so simple though, because the studies that have come out over the last 2 decades didn't always show a cardiovascular risk benefit. So it's a mixed bag. I want to contrast the difference in the benefit of statins versus aspirin. And so this study on the left was from 2003, and it's called the 2004. It's called the CARD study, and it showed a number needed to treat of 27. And this enrolled patients with atorvastatin at a 10 milligram dose. So not even a high intensity statin dose, and that's a significant benefit. Contrast that with the Esprit Trial, which was conducted in 2018, and the purpose of Esprit was to analyze patients with just diabetes and hopefully put this question to bed. Enrolled in over 30,000 patients, and over the course of 5 to 10 years, you started to see a benefit with aspirin in primary prevention. The number needed to treat in the Esprit trial was 90. One of the concerning features was that the bleeding risk was also higher. So number needed to harm 110. So the conclusion from the Esprit trial was that you're, again, picking your poison. And 80% of these patients had an A1C less than 8. The reason that I think the Esprit trial is the best study to date is that 75% of these patients were on a statin. So if you were ever going to ask the question, does an aspirin benefit patients with diabetes who are maximally medically treated on statin therapy, the Esprit trial gives you the answer. And the answer is yes, with a number needed to treat of 90. That said, it comes at a bleeding risk. Okay, so there's 3 trials. We just talked about one in terms of the recent trials from 2018. The next is the ARRIVE trial, which included moderate risk patients without diabetes. So the goal of this study was to recruit higher risk individuals and hopefully see a benefit for aspirin. So they enrolled over 12,000 patients, randomized 100 milligrams versus placebo. The average risk for this group, based on a PCE prediction, is 17% over 10 years. And almost half these patients were on statins. Interestingly, the event rate fell short. They actually tried to extend the study from 5 to 6 years just to get the event rate up, and they had to stop shortly. They even tried to include unstable angina and mini strokes, even though it wasn't proposed as an original outcome measure, and it still could not recruit enough patients with heart attacks. And so the number needed to treat, we don't know. It wasn't statistically significant. The number needed to harm is about 200 in this group. And notice the event rate. So even though the PCE predicted 17%, it was about half of that rate noticed if you were to extrapolate over the course of 10 years. Because again, it only ran for 5 to 6 years. And then I'll just mention briefly the quartiles. So they did a subgroup analysis, and you'd kind of expect that the higher risk group would have a more favorable hazard ratio, and that was not appreciated in the study. It was actually the lowest quartile that showed aspirin was most favorable. And I don't know how to explain that. It's just a little bit interesting. There was significant crossover in this trial as well as Esprit, and so that's one of the criticisms. So the conclusion, which I agree with, is that moderate risk patients were actually low risk based on the actual event rates. And number two, aspirin provided no benefit, but actually it still caused harm, albeit small. The last trial in 2018 was the Esprit Trial, and this recruited elderly patients above the age of 70. So you had to be living independently. So none of these patients were frail or had dementia or living in a nursing home. And they were randomized to 100 milligrams of aspirin versus placebo, and they were followed for about 5 years. There was several endpoints that they wanted to touch on, because the thought was, well, maybe aspirin doesn't prevent heart attack, but if it prevents mini strokes, progression of vascular dementia, maybe physical disability is a decent endpoint, or dementia. Unfortunately, the results were overwhelmingly showing that it does not benefit any of these particular outcomes. In fact, it actually showed an increase death from cancer-specific mortality, which of all things is surprising because of the retrospective studies showing that aspirin could prevent cancer. And so critics say, well, you need to follow these patients for longer than 5 years, because that's when you start to notice the benefit. And people that look at this study and see the increased mortality in the aspirin group take extreme caution. One of the scariest things is that major hemorrhage had a number needed to harm of 97. So similar to diabetes, these patients are higher risk to bleed. And I took the liberty of looking at the supplemental material, and if you isolated groups with a cutoff at age 65, the number needed to harm to cause one head bleed, sure, it's 1507 if you're less than 65, but if you're greater than 65, it's 324, and these numbers are not cited again in the publication, probably because they didn't reach statistical significance, but I think the signal is extremely unnerving. And then just to compare that number needed to harm to what I would quote as an appropriate number needed to treat using post-2000 randomized controlled trials representing modern era patients, you'd have to treat 1,000 patients to prevent one heart attack. And you'd only have to give 300 patients an aspirin to cause a brain bleed. I think that's very, very concerning. All right, so let's discuss the executive summary update 2019. So low-dose aspirin might be considered for primary prevention among select adults. So they have to be low bleeding risk, and they can't be older than the age of 70. That's their grade 2B recommendation. And when you see articles like this that say that aspirin's going to die on its 120th birthday, you wonder, is there any point to prescribing aspirin at all? Here's the final numbers that if you just take all 13 trials and including the ones that are before 2000 in a pre-statin era, you get the number needed to treat 241, number needed to harm 210. And for a patient who considers a bleeding event the same as a heart attack, then obviously it's not a good idea to prescribe aspirin. But I would go a little bit further. I think that the number needed to treat is significantly higher in the modern era, and as noted by the numbers I cited before. And so really, you probably shouldn't be prescribing aspirin unless someone's willing to have 2 or 3 major bleeds, defined as being hospitalized or needing a transfusion for every heart attack. So that's the question that we need to be asking patients. All right, I've been going kind of at light speed and just wanted to take a step back. So does anybody know what this is? This is the Franklin Institute in Philadelphia. It's where I went to college, and I just love learning about Benjamin Franklin and history and all the problems that were solved. For those of you who don't know, he invented bifocals. He invented the odometer because he would test mail carriage routes to find out which were the most efficient, before GPS was available. And so I think it's kind of fun to think about if he was alive today, if COVID would be solved by now. But he just kind of had a knack for thinking big picture from a public health perspective, but then also getting to the weeds and solving real problems. And I think that that's the challenge at hand with aspirin. And so we might not like this general prescription to move from liberal use of aspirin to more restricted use. I think it's getting at the right idea. And what's more is really, where should we be focusing our time? So if aspirin does have this blunted effect in the modern era, then maybe it just needs to be de-emphasized and we should be spending more time on things that matter. And so obviously, coronary artery disease, cerebrovascular disease, these accumulate with risk factors over a lifetime. And so primordial prevention is key. Here's Life Simple 7. And so this is probably where we should be spending the majority of our time with patients, blood pressure control, cholesterol reduction, avoiding blood sugars, avoiding trans fats, getting active, maintaining normal BMI, not smoking. I really love the quote below that's where our focus should be. So I should probably give a disclaimer before we get into my proposed shared decision-making framework for management of aspirin. This has not been externally validated. It goes beyond the guidelines. I think that reasonable people can agree, disagree on minor points, but it's also worth taking a stab at because there's got to be some guidance in how we prescribe aspirin for primary prevention moving forward, because clearly there are still high-risk patients that could benefit. We just need to identify who they are. So follow along. The first question that you need to ask is if there's a secondary indication for aspirin. If the answer is no, they've never had a heart attack, never had a stroke, don't have a stent, then you can move to age. So if they're younger than 40, again, the PCE is going to overestimate risk anyways, and so patients younger than 40 should not be considered for aspirin therapy in my perspective. And then if they're above the age of 70, then clearly there's this mortality uptick with the Esprit Trial, and certainly with rising risk of intracranial bleed, I would not recommend aspirin for anyone above the age of 70. So if they're within that age range, then we can move along to bleeding risk. Again, the risk of bleeding on aspirin is probably much higher than what's quoted in these studies because all of the patients as inclusion criteria were low bleeding risk. So keep that in mind. So if they're low bleeding risk, then you can get to calculating a 10-year ASCVD risk. We know that no patients should be considered for aspirin therapy, dating all the way back to guidelines that are 5 to 10 years old. If they are intermediate risk, then I think it comes down to patient preferences. So gone are the days that if a patient's biggest fear is bleeding, by no means should an intermediate risk patient be obligated to take an aspirin. Why? Because as the ARRIVE trial showed, these patients are probably lower risk than we suspect, and so they should just be put on a statin. If a patient wants to avoid colon cancer at all costs, I think following the USPSTF guidelines is still reasonable between the age of 50 and 60 when the bleeding risk is low. And then if they want to avoid an MI at all costs, then that's also reasonable as well. They're going to accept the bleeding risk, which again at lower ages up until age 65 and then really at 70, you see quite the uptick. And then if they have diabetes, then aspirin use should really be de-emphasized. There's so many new drugs between GLP-1s and SGLT2s that have been shown to improve cardiovascular mortality in a primary prevention group. And so there's at least 3 drugs that you can prescribe someone before giving them aspirin. And so what I do nowadays is I'll actually use it as a bridge rather than a destination therapy, as I'll get to in the high-risk group. Obviously, there are exceptions. If someone has a super strong family history or an A1C of 15, that might be the time that you use aspirin kind of as a bridge. But the point is we need to be reevaluating at each visit. And so if someone's risk factors are dynamic and suddenly improve from visit to visit over the course of 6 to 12 months, we also need to be reevaluating the risk-benefit ratio of aspirin. All right, and then in the highest risk group, greater than 20%, I think that there's probably 1 or 2 groups where you can still indiscriminately prescribe aspirin. And that would be if their A1C is above 8 or 8.5, depending on where you want to argue, or if they have a strong family history. I think that it's okay to start aspirins in that group. But still, if they don't have uncontrolled diabetes or a strong family history, then you are not obligated to put these patients on aspirin, whereas 5-10 years ago, we probably would have. Okay, so back to our case. So should Mr. Evans' aspirin be stopped? Well, I think the important point to ask him is whether or not his dad was on a statin. Probably not, and certainly not a high-intensity statin. So Lipitor became generic in, I think, 2014. And so, again, we haven't even seen the full extent of risk mitigation from high-intensity statins. And I think you can provide a significant amount of reassurance for patients just by intensifying their statin therapy. And there's actually this risk estimator plus that the ACCP provides online. And in his case, just by changing his simvastatin to atorvastatin, you're reducing his 10-year risk by 6%. I think when you put in the aspirin for that website, it only reduces it by 1% or 2%. And because he's 68, that would significantly increase his risk of having a brain bleed or a major bleed. Again, the number needed to harm at age 70 is only 100 for a major bleed, and possibly as low as mid 300s for a brain bleed. So that is not something that we should be routinely recommending for patients, and that's how I would manage him. Okay, so in conclusion, aspirin should not be the focus of primary prevention conversations until other modifiable risk factors are addressed. Aspirin has not been shown to improve mortality when used as primary prevention, and now we know it may increase mortality in elderly. Aspirin has not been shown to reduce cardiovascular events in patients on statin therapy. There's one exception with the Ascend trial, and that was in patients with diabetes with an average A1C of 8. And keep in mind that bleeding risk was more significant in that group. Patients with prior GI bleeds, peptic ulcer disease, dyspepsia, or advanced age should not be started on aspirin for primary prevention. It should only be low bleeding risk patients as candidates. And physicians should strongly recommend initiation of statins prior to aspirin because of the more favorable risk to benefit profile. The future studies for aspirin, I'd like more granular stratification data, especially with respect to diabetes, but also in patients with rheumatoid arthritis, with lupus, with psoriasis, gout. Just having more precise risk estimates would allow us to better tailor therapy in regards to aspirin for primary prevention. And when I mentioned A1Cs of 8 to 8.5, yes, it's part of that is due to the New England Journal dating back to 1998. But I also have looked at some of the mortality curves for diabetes based on A1C in more modern era patients, and the inflection point for when mortality starts to go up is still between that 8 and 8.5 point. And so I think that's a reasonable place to consider aspirin. And then finally, use of aspirin in primary prevention settings remains highly contingent on patient preferences and values. I hope that that algorithm for shared decision making is helpful to you. And I really, really am looking forward to the USPSTF's next iteration of guidelines, because again, looking at this from a lens of not just bleeding risk, not just cardiovascular prevention risk, but also cancer prevention risk is really, really tough. And there's not a single calculator that does that well. So that's the next big nut to crack. All right, here are my references. And at this point, I'm going to open it up for questions. I really enjoyed preparing this talk, and I'm excited to hear from you all. Thanks.